When we looked to see the participants in this session, we noticed that actually quite a few were not nurses. And so I am going to start out with some basic definitions of what advanced practice nurses are, and nurse practitioners and clinical nurse specialists, just to set the stage. And I'm going to then monitor my time because as an educator who tells every student never to have more than one slide per minute, I have more than one slide per minute. And so, but there is a spot where I can stop if I've gone over time. So off we go. So what is an advanced practice nurse? According to the ICN, and very close to the CNA, advanced practice nurse is a registered nurse, one who holds a graduate nursing degree, and who is an expert clinician with advanced clinical decision-making skills and a high level of autonomy. Advanced practice nurses have expanded scopes of practice and should have a formal credentialing process, and we'll be talking about that as we go along. I'm going to move these here just so I don't drop them down. Great. They have the following competencies. They have advanced clinical skills. They spend time educating not only patients, but their colleagues, physicians, nurses, and other members of the healthcare team. They spend their time, some of their time doing or consuming research so that they, in fact, can help to promote evidence-based practice. They spend time in professional leadership, either in the clinical setting and also in the profession. And they spend time consulting and collaborating. And in Canada, we have two types of advanced practice nurses. We have the clinical nurse specialist, and we have the nurse practitioner. And then there are types of nurse practitioners. There are nurse practitioners that we call specialist nurse practitioners. These work perhaps with adults who are NP adults, or in pediatrics with children. Those are NP pediatrics. We then have nurse practitioners who work in primary health care, and these are separate licensing exams for these nurse practitioners. And very recently in Canada, we have introduced nurse practitioners in anesthesia care. And the program is at the University of Toronto. And these are individuals who are already nurse practitioners who come and get additional education in order to become nurse practitioners with anesthesia care, delivering anesthesia care. So let's start with nurse practitioners. They are involved in health promotion, disease prevention, and acute and chronic illness management. They can diagnose in every province except Quebec, and where they are not yet allowed to make a diagnosis. They can order and interpret diagnostic tests, prescribe pharmaceuticals, and perform specific procedures within their legislated scope of practice. So in order to be a nurse practitioner in Canada, there is a separate and additional licensing exam because there are overlapping scopes of practice between the physician and nurse practitioner. Clinical nurse specialists contribute to the development of nursing knowledge and evidence-based practice and facilitate system change. So they are often the leaders in the clinical setting who are helping to promote best practice guideline use, helping nurses to use evidence-based practice. In the United States, a recent study has shown that hospitals who have attained magnet status, which is quite a prestigious status, that those hospitals, the attainment and the maintenance of that magnet status designation has a lot to do with having a clinical nurse specialist, at least a clinical nurse specialist on site. Clinical nurse specialists address complex healthcare issues for patients, families, other disciplines, and administrators and policymakers. So patients who pose particularly complex challenges, that they can bring the team together and they can coordinate the care of that patient. And they specialize in a specific area of practice that may be defined in terms of population, like adolescents or gerontology, or a setting, or a disease or medical specialty like diabetes, cardiology, type of care, or a type of problem. And this is a diagram, and Carl kindly said he had a pointer, and I said I wouldn't need it, but actually if I could borrow it, that would be great. This is a diagram that was developed by my colleague Denise Bryant-Lukosius. Thank you, Carl. And it I got that, yes, okay. And it just is a nice diagram for showing the difference between the clinical nurse specialist and nurse practitioner. So if we start with the clinical nurse specialist on this end and the nurse practitioner at this end, and all of the different competencies that I mentioned of advanced practice nurses, which all of these advanced practice nurses have, the clinical nurse specialist tends to spend more time in professional development of their colleagues, organizational leadership, research, and education, but some time in the clinical practice role. Whereas a nurse practitioner tends to do a bit of reverse, where they spend most of their time in clinical practice, and as you can see here with the dotted line, they also move into the expanded clinical functions requiring them to have an additional license, and that is not the case for the clinical nurse specialist. And we have a wavy line here because the roles are very dynamic and they are very influenced by patient needs at the time. And so there is a fluctuation in terms of the amount of time and the nature of time spent in direct patient care and those other activities that I mentioned. How many advanced practice nurses are there in Canada? A little bit complicated, but I can with lots of certainty tell you that there are about 2,500 nurse practitioners in Canada. The reason I can be quite certain about that is that they write a separate licensing exam and our regulators can tell us that information. And you can see that the majority of them are in Ontario, almost 1,500, and the next province is about 300 in Alberta. And that's high data. Now, when it comes to the clinical nurse specialist, one of the issues in Canada with clinical nurse specialists is that they do not have a separate credential because they stay within the scope of practice of the RN, and therefore the regulators will tell us that they don't need a separate credential. Of course, and that leads to the whole issue of self-reporting. And so we have about 2,200 clinical nurse specialists in Canada who call themselves that. But recent research that we have done has shown that if we apply the definition of a CNS, which is graduate education and a specialty area of practice, I would estimate that number to be closer to about 800 in this country. Okay, have APNs been evaluated and what have we learned about that? So we have done an unsystematic study. We're currently doing a systematic study, but we've done an unsystematic search of randomized controlled trials of advanced practice nurses and their effectiveness in terms of the outcomes that you see there. In terms of patient outcomes, looking at health status, quality of life, quality of care, patient satisfaction, in terms of provider satisfaction, those who work with the advanced practice nurse and the APNs themselves, and the health system. Do APNs have an impact on cost and length of stay? So very quickly, I'm going to show you the results of that. When it comes to primary healthcare nurse practitioners, there have been 28 randomized trials done over time, with the very first randomized trial done in Burlington, Ontario by Spitzer and his team in 1974. So 15 of them have been done in the United States, 8 in the UK, 2 in the Netherlands, and 3 in Canada. And if you look here, this row signifies studies that have demonstrated an improvement in those outcomes. This row shows studies that have demonstrated a decline in those outcomes, and this row shows no difference in these outcomes. And when it comes to primary care nurse practitioners, the comparator is usually family physicians, because we want to be sure that nurse practitioners who are taking on family physician roles are safe practitioners. So you can see here that there's lots of improvement in health status, patient satisfaction, costs, and length of stay. So each of those numbers represents one study that has found that outcome. One decline in cost with the primary care nurse practitioner, and the rest no difference, which is what, in fact, the hypothesis was for all of these studies. Very quickly, I can tell you this in terms of the decline, just because it shows how terrible the economic literature is about nurse practitioners, is that this was a study by Lydekker in the United States, where they compared a physician caring for people with diabetes and hypertension, and they compared that physician to another physician who had been partnered with a nurse practitioner. And in fact, they found that the partner team of the physician and the NP had significant reductions in glycated hemoglobin and in blood pressure, all great outcomes. And the way they did the cost was to say, but the intervention costs more because we have to add the cost of the nurse practitioner's salary. And that, as you all would imagine, is a very elementary method of doing an economic analysis without offsetting the cost of the NP salary with the improvement, of course, in pretty major chronic diseases. Now we'll look at the specialist NPs. These are our adults and our pediatric nurse practitioners, 18 trials, 10 of which were done in the United States, 6 in the UK, 1 in Australia, and 1 in Canada. And as you can see here, improvements in many outcomes that a number of studies found. One study found a decline in length of stay where the NP group did in fact stay in hospital longer than the physician group, and no difference in many of the studies, which again was the original hypothesis. And then finally, our CNSs, 32 trials, about half of which were conducted in the United States. And actually, when it comes to CNSs, we have the strongest body of evidence of the cost effectiveness of CNSs, who play a very big role in discharge planning that helps to reduce the length of hospital stay and also reduce the chance of readmission. Now, very recent, a colleague, Robin Newhouse in the United States, has done a systematic review of advanced practice nurses. Now, she included only published studies, and those conducted only in the US since 1990. She found 14 trials of nurse practitioners, 12 of which were high quality, which is terrific, and her final summary result was that the NP outcomes are similar to their comparison groups, so no difference. She found 4 randomized trials of CNSs that she called high quality, and she concluded that CNSs, as we saw with the studies, in acute care reduced the length of stay and cost of care for hospitalized patients. So without a doubt, we can be assured that advanced practice nurses are safe, effective practitioners. Okay, well, I was asked by Anne to address what possibilities are offered by advanced practice nurses to improve service delivery. So what I've handed out to everyone is 2 pages, one on nurse practitioners and one on clinical nurse specialists. We were recently asked by the government to develop these summaries, and they are evidence-based in that you'll see all the references at the back. And we tried there to summarize how APNs improve or provide better care for individuals, for populations, and in terms of cost efficiencies. You are the first audience to see these, and they're going to be widely distributed. They were created with a very active advisory panel of government officials and nurse leaders across the country and the CMA, but we very much would appreciate your input on them. But when it comes to better care for individuals, we find that APNs play a very big role in increasing access to care. As you know, with primary care and the recent shortage of physicians that we have had, nurse practitioners have been able to increase access for patients who do not have primary health care through services like nurse practitioner-led clinics in Ontario. In acute care, the specialty nurses increase continuity of care with working with physicians who are very busy and finding it hard to manage all of the patient load. They have been shown to reduce emergency department wait times, and they have been shown to increase timeliness of care for people in long-term care, because in long-term care relies on often a medical director who's trying to run a practice and is being called by the long-term care setting, whereas in Ontario, Nova Scotia, and other provinces, they've now introduced nurse practitioners in long-term care who can handle that upper respiratory infection before it becomes pneumonia and before they're transferring the patient to the emergency department. Russell and colleagues here at the University of Ottawa have showed that, regardless of the type of primary care model, if the model included a nurse practitioner, they were able to demonstrate improved chronic disease management. We're able to find increased access to supportive care for patients through the case management role that the clinical nurse specialist plays, and improved quality of care through the promotion of quality improvement and evidence-based care that the clinical nurse specialist facilitates with the nursing staff in the hospitals. In terms of better care for populations, we see increased access to care for vulnerable, isolated groups, those in rural and remote communities where, as you know, many NPs have played big roles, and also CNSs with Aboriginal people in Canada through Health Canada. They have a role with the consultation and specialized care that they provide for those that need complex disease management, palliative care, and mental health care. They are able to facilitate greater involvement of patients in their care, thank you, and improved health promotion practices such as immunization rates and participation in cancer screening. When it comes to lower costs, and I will be the first to say that the research on this needs to be better, but what we know about the research so far is that one study from the Netherlands, recently published a randomized trial, showed that there were lower costs associated with the nurse practitioner in general practice. Certainly we do know through the CNS research that there are reduced hospital admissions, and with the NPs, reduced ED visits, reduced length of hospital stay and readmissions, which saves a lot of money, reduced avoidable ED transfers to long-term care for the reasons that I described earlier, and improved discharge planning and home follow-up, which reduces overall healthcare costs. So we were asked to conduct a review of the literature and do stakeholder interviews to create a decision support synthesis about APNs. And we did a scoping review of the literature where we summarized about 500 papers, which were all the Canadian papers of any type or date on APNs and international review papers over the 5-year period of 2003 to 2008. And we also interviewed 81 key stakeholders, mostly in Canada, but also in the UK and Australia, who were APNs, government policymakers, nurse administrators, regulators, educators, physicians, and other healthcare team members. And in these last 3 slides, what I will show is what if the outcomes for APNs can be so good, and in fact we can improve patient outcomes and population outcomes and lower costs, why aren't APNs able to be fully integrated into the Canadian healthcare system despite a 40-year history of each role having been developed? And while I'll give you a very brief summary, the full decision support synthesis was published in a special issue of the Canadian Journal of Nursing Leadership with 10 papers, peer-reviewed, and guest edited by Dot Pringle, thank you, and fully and freely available online at the URL that's there and easy to find on the Longwoods website. So what the general facilitators to APN role integration, what really helps to integrate them? One is having a systematic patient-focused plan to guide the role development. Because sometimes we have this little bit of money that the government has left over and gives it and says, how about using this money for an APN role? And then there's this knee-jerk reaction of what are we going to do with the role? So if we could go through a systematic plan that determines what the patient needs are that the APN role should address, then the role is much more likely to be effective. If we have clearly defined roles, is it a physician substitute role? Is it a physician complementary role? There's different times when those roles are important. Then that really helps to integrate. And public and health provider awareness and acceptance. And that was another reason why we developed the one-pagers that you have. And so with the primary care nurse practitioner, the biggest facilitators that have helped this role is the government legislation and regulation, which now exists in all provinces and territories in Canada, but only since 2009. There is government funding available for the positions, which of course makes it easier to implement them. And as you all know, we have a big emphasis on interprofessional collaboration in Canada now, which of course has facilitated that and a shift away from fee-for-service payment models for physicians. But the challenges are that, and this, I would say, is more at the professional organization level rather than at the frontline patient level. But sometimes working out the relationship between the two autonomous clinicians of nurse practitioners and clinicians, physicians, can, with a substantial overlap, can create some challenges and some conflicts. But as I say, I see it much more at the professional level than I see it at the bedside level. Inconsistencies in educational preparation in Canada, but we're moving where it has been that in Ontario, nurse practitioners were not prepared at the master's level. But we are moving so that pretty well every province in Canada will have NPs prepared at the master's level. And lack of rigorous studies to examine their cost effectiveness. Facilitators for the specialist NP is lots of support from the medical and nursing administrators in hospitals who really appreciate working with the NP in neonatology, cardiology, neurology, because the physicians are busy with patient care, education, and research, and they really appreciate the support they can give one another. And then the challenges are difficulty implementing the non-clinical roles because there's such a pressure for direct patient care. Limitations to scope of practice due to hospital restrictions. So even though NPs can prescribe, the Public Hospital Act doesn't let them prescribe, and so they still have to work with delegated medical acts. Inconsistent team acceptance and funding of the role, which is an important issue because the NP, a specialist NP, is paid through the hospital budget, and hospital budgets are being cut back more and more, and so hospitals are realizing that if they hired a physician instead of an NP, the physician could bill the government for money, and the hospital wouldn't have to pay the NP, and so that's a big issue we need to think about. And last, the CNSs. The facilitators for the CNS role are the supportive health administrators and the increased emphasis on evidence-based practice. And these are our individuals who can facilitate that in the healthcare organizations. But there are lots of challenges in Canada. There's a lack of a common vision and understanding of the CNS role. There's limited access, in fact, I don't think there is any access to CNS-specific graduate education. And there is a lack of title protection and credentialing. So there's no way at this point in time of being able to say who is a CNS and who is not. So I'll just end with where we're moving. We are told by governments, and we're moving that way to say, yes, it's not enough to say that APNs are safe, effective practitioners. Show us the value added of APNs. And so we're all going to be moving forward to sort that out. We're currently doing a systematic review of the cost effectiveness of APNs, and then we actually got funding from CIHR to bring together health economists across the country in the fall to help us work out an economic modeling for APN. So we're very excited about that. And there's lots of research needed on the CNS role. There's very little of that in Canada. If anyone's interested, there is a Mythbuster, seeing an NP instead of a doctor of second-class care through CHSRF at this URL, and also the OECD in Paris in July of 2010 prepared a paper on nurses in advanced roles, and one of those 12 countries was Canada. Thank you very much.